Good morning, everyone. It's a pleasure to be here, and I want to thank the organizers and Rebecca and Melody and others for the invitation to speak today. So I was asked to talk about global and what we're going to do in terms of Canada and Canadian opportunities. And before I get into it, I want to reflect on this slide that even though we know that the imaging, regular imaging, nuclear medicine are both much higher in terms of the billions that are invested in them, but if you look at the annual growth, the compound annual growth, theranostics is 29%. So, is it an easy way forward? No, it's not. We know that there are some challenges. We've heard a lot about these challenges yesterday, from production challenges, supply chain, regulatory, and the list goes on. But we have a good opportunity, all of us here in this room, to move the needle forward and do something positive for our patients. Production of radioisotopes, all of you are familiar, we went through this of different types, but what I wanted to bring to your attention is that there are databases that are looking at this. So we have the PRIS database, which looks at nuclear power status around the world. So that's a very important way of tracking what's happening, and this is led by the IAEA. We also have the IMAGINE database that looks at cyclotrons, and for this one, it's very obvious when you look at the map that there is significant inequity around the world. If you look at Africa, for example, you see a lot of gray where you don't have a lot of anything available and so forth. But databases are not the only way we can look at this. We have other things like missions that we do, different types of missions, quality assurance missions, various other types, and also, of course, Lancet commissions, as you've heard. So, this is an example from the IAEA IMAGINE database, and I'll just highlight the low income versus upper income, where you have one PET scanner for 250 million people, and you have one PET scanner for 0.3 million people. Same thing is going on in CT, same thing is going on in SPECT. It is inequitable. So an example of Africa, and here we see that 20 countries have no in vivo nuclear medicine at all. And the ones that have significant numbers, more than 10 cameras, are all in the north and the south. So why is this happening? Well, we know cost is an issue, government support is an issue, the economy is an issue, but also shortage of healthcare workers, and I think that's something that we don't hear a lot about. So what about workforce? Well, the Lancet Oncology Commission looked at that, and as you can see, there's a significant inequity again. But the good news is, if you look at Canada, we're doing very well. With the exception of, as we heard yesterday, radiopharmacy, where some programs are going to be set up. And we heard that talked about yesterday. But still, because of the multidisciplinarity of this particular theranostics initiatives, we need more training and workforce. Okay, so what's Canada's role in this? Well, we know that Canada has been a long-standing global supplier. We know that you're already supplying isotopes for tens of millions of procedures. We also know that it's a diversified production, which is a good strength. And a significant thing is the end-to-end supply chain, which is not common in many situations. We have government that is very supportive. We have specialized equipment and technology, training and research institutions, and many other very positive things, which means that it's a great opportunity for Canada really to take the lead in this area. So one example of how important the processes in Canada are is what happened, and many of us who were practicing back then remember how difficult it was to get PET CTs done because of exactly this. The Chalk River was closed and created a whole global issue at the time. So that's some background, but now a little bit about the IAEA for those who are not familiar with the IAEA. So what is the IAEA? You heard Mary said in her introduction that we are the global focal point for nuclear and radiation, which means that whether it's health, whether it's agriculture, whatever we use radiation for, the IAEA is the place to go. We work from the beginning of setting up centers all the way to research and innovation and so forth, and of course policy and guidance. So the assessment of needs, I explained a little bit about that. Infrastructure development and appropriate equipment. So we're working a lot in this area, and I'll share with you some of the Rays of Hope initiatives that have been happening and other types of projects that we have been doing. And then capacity building. Without a proper workforce, we're not going to get anywhere. This is a very important part, and in many cases, many countries around the world overlook it, and not only overlook it, but overlook the cost and the time it takes to prepare people for this. Promoting quality and safety, it's not okay to set up centers unless we're sure that they have good quality and safety for patients and for others, the workers in there. Then the pipeline, coordinated research projects, and this is an invitation for people who are interested in the research aspect. We have both the production research that's ongoing, work with nuclear energy as well, but also implementation research and clinical research on the use of certain isotopes. And then continuing education through hybrid and digital opportunities. So covers a lot of different areas, as you can see. So I don't have much time because it's a limited amount of time that we have to speak about so many things today. But I'd like to share with you an example of the national regional projects that we have. And for each project the IAEA we have a management officer, we call them PMOs, and a technical officer for these particular projects. Here we have over 430 projects that are ongoing. All the projects that are ongoing right now, the 439, are human health projects. But of the whole technical cooperation program, 25% are health. So health is requested by our member states significantly. So what does that mean exactly? Well, it means like for a typical year, you would train 90 people. You would have 25 large training courses. For a typical year, you'd have 60 expert missions, meaning we'd send an expert to the country to assist in commissioning or whatever else they need. And we buy a lot of equipment. So what else do we do other than these projects? We have guidance documents. So this is an example where if someone wants to develop a curriculum for medical physics, for RTTs, for whatever, especially nuclear medicine physicians, we have that guidance. We also have audit methodology as well for the clinical training, which is an issue in many countries, especially for clinical medical physics and so forth. And this wheel is available on the Human Health Campus. You just click on whichever document you want and you can download it. So this is the Human Health Campus. It also has interactive e-learning modules. It also has rover and complete curricula and many other activities. Virtual tumor boards happen, webinars happen, so many things. Then I just have one slide on research because of the time limit, but I'd be happy to talk to whoever's interested. So research, all these countries around the world have been involved in our research. We have 51 CRPs, what are called coordinated research projects, since 2011. We have 22 active projects, and they vary from dosimetry research to, and this is only for human health, but we have a similar number of research projects for production, for example. So before the phase 2 on trials. We also have health economic research, implementation research, all kinds, and of course clinical trials. So you can see that we do it in cancer, but also in cardiac and in neurologic diseases. Of course, this is more familiar to most people. The safety part, basic safety standards and other safety standards series, they're the building block of all that we do, really. And then, of course, opportunities like waste management, good practices for introducing radiopharmaceuticals. The list is very long, and there's no time to really go over everything that's done here. And quality assurance methodology, which I didn't mention as well. So very briefly, the Rays of Hope initiative. You've heard a little bit from Mary about it in the introduction, but the Rays of Hope initiative includes over 95 countries. And not only that, but when we were designing it, we were thinking of the 3 pillars. Obviously, the first one everybody recognizes. We want to buy equipment, we want to train people. Everybody recognizes that. The second is something we really pushed hard for, which is the anchor centers or the regional centers of excellence. And the reason we did that is because we have been sending support and training people and buying equipment for decades through the IAEA. But many times countries will fail after we've started something. So we thought if we had sustainable centers, regional centers of excellence that could support these countries, maybe they would have a chance in terms of long-term sustainability and support within the region. Then the last one is innovation. And with that, we have 2 steps. The first one is developing a global database called Sunrise, which we would be very happy to discuss as well afterwards. And that one is to look at their impact. So we're doing all this stuff. Are we really changing anything? So that's going to collect patient data and also health economic data and machine data. And then the second phase is we're working on trying to improve the infrastructure, the research infrastructure, to be able to have one day down the road, long term, regional cooperative groups for research. So this is just a quick example of things that, a couple of examples from Africa, Benin, we procured cyclotron, Ethiopia, development of nuclear medicine facility, and that includes, of course, training of people. These are examples of things that happen, national and regional training that we have. We've had regional training, for example, on theranostics. We have online training on research and quality assurance and various other things. We've had expert missions to these anchor centers. You see this Argentina, Algeria, Japan, Pakistan, South Africa, and we send these expert missions to look at the infrastructure, quality assurance, research, and education, and to see if there are opportunities to support. Virtual meetings on theranostics, for example, and so forth. And that's in addition to our regular conferences that we have at least once a year that usually has 600 people from 94 to 95 countries. And also we have about 2,000, 3,000 virtually. Okay, so now moving on to policy and how we influence policy. So this is a good example, and Mary alluded to it. So we started the Lancet Oncology Commission on Radiology and Nuclear Medicine in 2018. We launched the report in 2021, and then we started negotiations towards a World Health Assembly resolution. Cameroon was the first country to accept to move forward with that and took it to WHO, where the World Health Assembly adopted the resolution in 2025. And why is this important? Well, once you have this resolution, it's a commitment by countries to report on progress in imaging and nuclear medicine. And theranostics, by the way, is in the imaging resolution as well. So from a political perspective, this is a building block for the future. So what can Canada do in terms of the World Health Assembly implementation? It's resolution 78.13. So it says, make medical imaging available, address financial workforce and barriers, promote safe and high quality imaging and nuclear medicine. So I think the diagnostic supply is very helpful. And then as a reference architecture for this transferable template that others can use as well and how things are done is going to be important, and for a source of theranostic supply. Other things, of course, workforce was in there. As you see, workforce is extremely important. We can't live without workforce, so that's part of it. But guess what? We have great Canadian universities that we're all aware of that can really contribute in this area. And then reporting to WHO through the coalition, so involvement in the coalition, involvement with IAEA, and involvement and collaboration with WHO and IAEA in safety and other will help us be able to give that information and move it forward. And this is a shout out to a really exciting Isotopes for Hope that as we move forward, I think the whole environment here is so positive and really going in the right direction. So CNIC, I believe James is here, and we have a practical arrangement with CNIC, the IAEA does. And we see that there's going to be a lot of investment and support from government and other things that are supporting this process within Canada. But I would say that a good opportunity for IAEA support, and a shout out to the activities that are already happening within Canada. So in conclusion, we know there's a need and we know that there are gaps. That's pretty obvious, and we talk about them all the time. But now we have a good producer country responsibility, how it looks like in practice, and how a commitment to double outputs can look, and how the infrastructure that allows this to happen and the template for that is. So this is a very good example. And then finally, from the IAEA perspective, we convene the producers, the recipients, we build member state capacity to support us moving forward as we take that trip together and fight the sickness together. Thank you very much.